Next, I'm going to introduce Christan Martone and Bobby Ardil. They're going to speak to you a little bit about incontinence, post-prostatectomy, the mechanisms of actions, and kind of explain some of the anatomy. When we do a prostatectomy, we basically destroy the continence mechanism of the male pelvis, but there are certain things we do during surgery to reconstruct that and what we do after.
As Dr. Patel said, we are going to talk about the return of urinary control after prostatectomy, which will be followed by everyone's top three concerns, which is the return of erections. We'll get into that later. Oh, thank you. Okay. So briefly, we are going to go over the types of incontinence. Stress incontinence means you'll have a little bit of leakage when you laugh, sneeze, cough, maybe bend over to pick something up. Anything that's going to increase the pressure in the abdomen and therefore the bladder, and you're going to get a little bit of leakage. Urge incontinence, on the other hand, is that incontinence associated with the urge to go to the bathroom. The I have to go right now or I'm not going to make it sensation. And then mixed incontinence is just the combination of both. So then the stress incontinence we're going to focus on shortly here is a pelvic floor issue. It's related to the weak pelvic floor muscles. As you see here, and I don't have a pointer as well, essentially we remove the prostate by cutting above the prostate and below the prostate and connecting the bladder neck and the urethra back together, which I'll have Bobby talk about because he's right there at the bedside in the OR.
Hello. We get many questions when we see patients in clinic. Most of the time up in the OR with Dr. Patel, but often patients here is like, well, when they do this reanastomosis and regarding leaking and incontinence, I want to give you a little different perspective with anatomy and from the OR standpoint. You see the prostate and you see the urethra going through the prostate from the bladder. And what we refer the bladder neck is basically when the prostate is cut out and there's a little window, which we refer to as a bladder neck, is actually connected with, you may see down where it says the sphincter edge, which actually is the rhabdosphincter covers the urethra. So the prostate is cut between that point and the bladder, and that's where the reanastomosis occurs. Where's the next slide? This picture kind of illustrates it's albeit animated. If you see where it says prosthetic and static system of the pelvis, when the prostate's removed, it causes some disruption. It's kind of if the prostate's on the stage, if you will, there's several connective tissue props, if you will, that are kind of cut, and the thought is through the years that that there was problems with incontinence, but obviously we've improved, and some of the things that have been illustrated and Dr. Patel mentioned, as well as the technological advancements with the robotics, has improved that. Also to point out, some people and patients have asked, and I'm trying to refresh my memory to cover some questions that I've been asked often. The prostate is housed very close to the rectum, and there's a thin area that some people have some discomfort with their first becoming regular with the first bowel movement after prostate surgery. Just to kind of give you a better perspective that it's so close, so when Dr. Patel is actually working on that anastomosis site and the posterior reconnection, which we're going to discuss in a minute, that it's very, very, very close to the rectum, just so you get an added perspective on that. Here it kind of explains a little bit better. The first suture line, there's three stages of suturing. One is at the bladder neck, and the second is at the posterior part, and then the third is the final anastomosis, which some of you are familiar, coming back with a catheter, getting the cystogram, and making sure that there's no leaks. It's directly related to this in animated form here. You see the first line in the picture above. That first suture line is actually bringing what we call the posterior plane. You see the urethra, and obviously that's important because it'll carry the bladder, urine from the bladder on out. So this part of reconnecting, if you will, the area around the urethra is referred as the rhabdosphincter, and at what we call the lower edge or the caudal edge, and the upper cranial edge is referred to as Denaviers fascia, which just right below that is a very thin fat pad, and then below that is the rectum, just to give you a better perspective. And then the lower edge, the second suture line is actually bringing what we refer to as that bladder neck to that urethral stump, thereby obviously facilitating urinating once again. In that area, just to point out, there's been a lot of studies to support an early return of continence. So that's what's so unique about this perspective of surgery and following up from the patient standpoint. And obviously, one of the biggest concerns is not just potency, which Mary's going to discuss in a minute, but the return of continence and becoming drier a lot sooner. So one thing to differentiate the explanation, which I just mentioned, what we call the posterior suturing. Some places they don't do that, and there's been some positive evidence to support that it can interfere with an earlier continence return. So by doing this, this stitch actually enhances, and we've seen actually patients have a return to continence and become drier a lot sooner. And this just further illustrates, just so you get an idea, the suturing. So you'll see from the upper diagram, you can actually see more posterior, or the lower edge at a 6 o'clock suturing, and then actually comes around more anterior. So you actually have a full circumferential, very patent water integrity, a tight proof closure. Okay, this is, as we just kind of explained, the posterior reconstruction. And same thing as far as a significant shorter interval for recovery of continence following surgery, especially within the first 3 months. It's pretty significant. Okay. And Kegels, as you hear often, I try to make sure when I'm initially seeing patients to kind of give them a timeline. In Kegels, and a lot of times they get a little nudge from their wife or girlfriend because you hear a lot more in childbearing women. They're familiar with that. But a very similar concept in strengthening lower pelvic muscles. As we had just mentioned, ideally to get a return to continence a lot sooner. So, let's see. And you remember the classes that Mary gives, and do you want to talk about this?
Sure. Okay. Did everybody get that surgical aspect down? All right. So the Kegel exercise is to strengthen that pelvic floor to bulk up those muscles so you can kind of combat some of that leaking and dribbling after surgery. And as guys, you're not really in tune with your pelvic floor muscles. So the way to find them is to urinate. Cut your urine midstream, like you're slowly turning off a faucet, and hold for 5 to 10 seconds. That's the pelvic floor. We don't want you doing it just when you're urinating because that's not going to be enough times during the day to bulk up that muscle. And by bulking up that muscle, it's going to make that urethra more tight, more narrow, so you don't have that leakage. So doing these exercises, do them, when it's convenient for you. When you're watching TV, maybe standing, waiting in the line at the grocery store. Just don't do them laying down because you guys aren't going to leak when you lay down. There's no gravity and you're not moving. And when you're doing these, your abdominal muscles and your glute muscles should not be moving. It's more subtle. The anus will be contracting because it is closely related to the pelvic floor. Okay, so again, just cut your urine midstream, hold for 5 to 10 seconds, and then specifically after surgery, on the third day the catheter comes out, we have you guys do a lot of these just to bulk up that muscle pretty quickly. If you notice any soreness anywhere from the anus to the scrotum, that just means, yes, you're hitting the right muscle, but as guys, you've never really used it before, so it's a little bit fatigued. What you can do, you can take a day or two off, or you can decrease the amount of time that you're squeezing that muscle, okay? So now we're going to transition from the stress incontinence to the urge incontinence. Okay, this is a bladder issue, and it's most commonly seen after prostatectomy with guys that had a very large prostate. And as you can see, normal prostate, normal bladder, the bladder is just free to drain. Here on this side, you have a very, very large prostate that's obstructing the urethra and clamping off that channel. So what happens when you have an enlarged prostate, the bladder has to work so much harder to get past that large prostate that it's continually contracting and pumping and working. And the bladder is a muscle. Like any muscle that you're going to keep, working out, it's going to get bigger. And I don't think this picture does a really good job of showing you that the bladder is actually very thickened, and that's what happens. Once the prostate comes out, the bladder might not know it's not there. So you still might do some of the same things that you did before surgery, maybe getting up a lot, running to the bathroom, that sort of thing. There's a little bit of an adjustment period where the bladder has to learn, there's no more prostate here, I'm just free to kind of empty. Okay, so the normal size prostate is about 25 to 30 grams, or about the size of a walnut. And when you come in to see us on that day that you have the catheter out, we go over this with you, and it's also on your page of your pathology. If anyone was curious, how big they were. All right. So what if you're still dealing with this urge incontinence? There are things that we can do. First, look at your pathology size and also that paperwork that you filled out regarding your urinary habits. The higher the score, the higher the symptoms for an enlarged prostate, and we take these into consideration. And if you're still having issues, we can put you on a medication to slow down your bladder, to make it, not so overactive, so it's not working all the time. And you might have seen these medications on TV, Toviaz, Vesicare. Before we put you on these, we want to make sure that you're emptying completely, and that's what the middle picture is about, is a bladder scan, because these medications are working to slow the bladder down. I want to make sure your bladder is working appropriately, because I don't want to slow it down even more. I could throw you into retention, and you guys wouldn't like that. These medications aren't long-term, they're just kind of in the period where you're regaining your control after surgery, just so it's a little more helpful. So then what if after some time you guys are still leaking? I want to make sure there's not a bladder infection going on in the lining of the bladder, because that's sometimes the first sign guys say, come back, I'm leaking a little bit more, you could have an infection, so we'll make sure that isn't going on with the urinalysis. And then the urodynamic studies is just a test to kind of see the function of the bladder. And then cystoscopy, which is just a camera test up the penis to take a look inside the urethra and the bladder. Some of you guys might have had this prior to surgery. The last two we don't do on everyone, kind of a patient-to-patient basis based on your history. All right, so then things to keep in mind especially why you're regaining your control after the catheter comes out. Avoid bladder irritants, things like caffeine, citrus, alcohol, cranberry juice. These things are going to make the urine very, very concentrated, very acidic. And so what happens is that concentrated urine is sitting in the bladder, and it's very irritating to the lining and the bladder itself. So it's going to make you run to the bathroom a little bit more. It's going to make you leak a little bit more. Okay, so when you're regaining your control, kind of cut back on these things. And even, after you're dry and you've, done your Kegels and everything is well and good, these things are still very irritating to the bladder. So kind of slowly add them back in and see how they affect you. I know if I have, a big pot of coffee, I'm running to the bathroom myself. So it's not just for you guys, it's for everyone. And then wearing darker pants when you're regaining your control, just in case you have an accident, it's not so obvious if you were wearing khakis or something. And then avoid wearing boxers. In boxers, there's no support for the penis. So we ask that maybe sometimes you wear boxers to kind of keep everything close together. You can actually tuck your penis up so that there's no gravity, so you don't have that dripping. Okay, some people find that works really well for them. And then I give everyone permission here to discontinue the pads or the undergarments when you notice less than a tablespoon of urine on the pad. That tells me and all the other clinicians that you're not really using it. You don't need it at that point. It's kind of mind over matter, okay? If you know the pad is there, you're not going to do everything you can to squeeze that muscle and prevent that leakage. Really want your brain taking over at that point, okay? So I would recommend start slow, start on the weekends, take the pad off, and then if you have an accident, you can take care of it there. And then once you gain more confidence over the weekends, kind of transition away from wearing that pad altogether so you don't need them, okay? That's the end. Okay.
Thank you, Kristen and Bobby.